You're listening to the lecture on management of patients with gastric and duodenal disorders. Objectives are to compare the etiology, clinical manifestations, and management of acute gastritis, chronic gastritis, and peptic ulcer disease. Use the nursing process as a framework for care of patients with peptic ulcer disease. Apply the nursing process as a framework for care of patients with gastric cancer. And discuss the etiology, clinical manifestations, and management of tumors of the small intestine. Acute gastritis can be classified as erosive or non-erosive. It's based on the pathologic manifestations present in the gastric mucosa. Erosive gastritis is most often caused by local irritants, such as things that you put in your stomach, NSAIDs, alcohol, and then localized radiation therapy to the area where the stomach's at. Non-erosive form is most often caused by H. pylori, which is a bacteria. Signs and symptoms of acute versus chronic are listed in the slide. There are different manifestations based on if it is acute or chronic. The signs and symptoms will be slightly different. Diagnosis is done by an upper GI, an X-ray, or endoscopy, and then they'll take a biopsy. As far as management, acute and chronic are slightly different. Management is mainly supportive for both. If it's acute, then you can have a NG tube, antacids, H2 blockers, PPIs, IV fluids, and then chronic is generally managed by diet modification, reducing stress, avoiding alcohol, avoiding the NSAIDs, and then being on the same types of medications that you would for acute. As far as nursing interventions, you're going to make sure they have adequate nutrition, reduce their anxiety, help them with positive coping mechanisms, monitor intake and output, make sure that they do not become dehydrated or have electrolyte imbalances since you are talking about the stomach. And then you're going to look at signs and symptoms for a GI bleed. As far as peptic ulcer disease is a very common. It requires hospitalization for 30 out of every 100 patients that are diagnosed with it. You might have also heard it be called gastric ulcer, duodenal ulcer, esophageal ulcer disease, and that just is because of where it is located within the GI tract. In the past, peptic ulcer disease was thought to be caused by stress or anxiety. However, most result from the bacteria H. pylori. Not stress or anxiety. NSAIDs are also a major risk factor, especially if the patient has H. pylori and is on NSAIDs, then this can exacerbate the symptoms. Symptoms can last from days to weeks to months. They can resolve on their own or they can resolve with treatment. Treatment is most often a combination of antibiotics and PPIs. They'll be on 2 different antibiotics with the PPI for 10 to 14 days, and then they can also add bismuth salts if they need to. As far as what the nurse can do, you'll do a general assessment, do a pain assessment, what makes it better or worse, what have they tried at home, get a good dietary intake, see if you notice any patterns with what they're eating and the symptoms. Look at their lifestyle habits. Are they smoking cigarettes? Are using any kind of nicotine? Any alcohol use or abuse? Any illegal substances? Any vaping? Anything like that. Look at the medications they're currently taking. See if they have any kind of NSAIDs that they take regularly. And then also see if they're taking anything over the counter for acid reflux or stomach pain. You want to make sure you ask about Pepto-Bismol specifically because that does have aspirin in it. See if they have any signs and symptoms of GI bleed, and then you'll do a good abdominal assessment. You can ask them about their stools. What do they look like? How often do they go? And then you can ask if they've had any vomiting. What does that emesis look like as well? There are potential complications with peptic ulcer disease. One of those is hemorrhage, and gastritis and hemorrhage, or gastritis and peptic ulcer disease commonly do have GI bleeding, and they're the 2 most common reasons for upper GI tract bleeding. If they have a large amount of bleeding, then they will be vomiting, and they'll vomit bright red or dark coffee ground looking emesis. 200 to 300 milliliters or more is usually vomited. If they have a GI bleed and it's a slow bleed, then the blood will actually pass through the GI tract and come out in the stool. So the stool will be black and tarry, and that's why we do the occult blood samples. And you usually do those 3 separate samples. Nurses need to monitor for hemoglobin and hematocrit to see if they're anemic, and then also see the trending. If they're lower than they normally are, they continue to drop, then that can be a sign of a GI bleed. Test the stool for occult blood, record urinary output to make sure they don't have oliguria. Sometimes, many times actually, if it's a slow bleed, the bleeding will stop on its own. If it does not stop on its own, then surgery will be required. Perforation has already been covered, but it's an erosion of the ulcer through the gastric serosa into the peritoneal cavity. It requires immediate surgery and is the most lethal complication of peptic ulcer disease. Penetration, on the other hand, is an erosion of the ulcer through the gastric serosa into adjacent structures. So instead of going into the peritoneal cavity, the erosion goes into the pancreas, biliary tract, gastrohepatic, omentum. Signs and symptoms are going to be back and epigastric pain that's not relieved by medications. This also requires surgical intervention. And then you have gastric outlet obstruction, or GOO. The area distal to the pyloric sphincter will become scarred and stenotic. And this can happen from spasms or edema or scar tissue from having ulcers that heal and then come back and then heal. And so you have that cycle of the ulceration with the scar formation. Signs and symptoms include nausea, vomiting, constipation, feeling full in the epigastric region, anorexia, and weight loss. Treatment generally is NG tube connected to suction, so you have decompression. Diagnosis, they assess the amount of the fluid that's aspirated from the NG tube. Residuals greater than 400 milliliters will suggest an obstruction, and then they'll do an upper GI or an endoscopy to confirm GOO. In addition to the NG decompression, you need to make sure that you manage the extracellular fluid volume as well as electrolyte balances, and this can help improve the patient's condition and possibly avoid need for surgery. Otherwise, they will have surgical intervention. You can relieve pain and discomfort by giving them the prescription medications, whether it's the antacid or the PPI or the H2 antagonist. It just kind of depends. Make sure that they avoid aspirin, NSAIDs, and alcohol. So if they have prescriptions for anything that's an NSAID or aspirin for pain, you would want to get that changed. Okay. You're going to help reduce their anxiety. See if you can identify what makes them anxious or stressed, and are they able to change it or not. Sometimes they are, sometimes they're not. Sometimes you can't remove the stressors if it's a job or a partner or children, financial status, but you can have better coping mechanisms, and you can teach them that. They need to be educated on their medication that they're taking, as well as medications to avoid, any dietary restrictions, and then any lifestyle changes. So stop smoking, no more alcohol, and then if they can identify what causes the irritation. As far as dietary restrictions, they should avoid that as well. Management of potential complications. So for a hemorrhage, you're going to assess to see if they have a GI bleed or hemorrhage. You might need to do an NG, but you have to be careful because if they have a GI bleed and you stick that in there and you're doing decompression, then you can actually cause more bleeding. They can be put on oxygen. If they go into hypovolemic shock, then you would do what's needed in order to treat the shock. As far as GOO, you would, again, NG to decompression, look at IV fluids, and you'll be monitoring intake and output as well as fluid balance. They can have surgery. They can also send down the tube with the balloon and inflate the balloon and try and stretch where the obstruction is. If they have perforation or penetration, then they need to go into surgery immediately. As far as gastric cancer, it is more common in men, more common in older adults, the Hispanic Americans, the African Americans, as well as the Asian or Pacific Islanders. Worldwide, it is the 5th most common cancer diagnosis. Diets high in smoked, salted, or pickled foods, as well as low in fruits and vegetables, can increase the risk of gastric cancer. Prognosis is generally poor because the patients remain asymptomatic in their early stages. So by the time they're actually diagnosed, the cancer has spread. The adenocarcinoma is the most common type of cancer. And because prognosis is poor, treatment, you can have palliative surgery. You can try surgical interventions, but most of it's going to be palliative or supportive. As far as caring for patients with gastric cancer, what kind of support and family support, friends, social support, that's really important. What kind of resources do they have? You'll do your head-to-toe physical assessment, and then you'll do a really good abdominal assessment because it can metastasize. You need to take that into consideration when you're doing your assessment. So, you can ask about bowel and bladder, you can ask about the kidneys, you can ask about breathing, find out if they have any history of smoking or alcohol, find out what kind of diet they usually follow, if they like to barbecue a lot, that sort of thing. As far as anxiety, again, positive coping mechanisms, explain everything to them before you do it, and then as you do it, make sure you're explaining it to them as well. See if they have any spiritual advisors that they would like you to contact, counselors that can help them through it. There's also support groups for the patient and the family, and then there's always hospice and palliative care if they're to that point. Make sure that they have optimal nutrition. Generally recommend 5 to 6 smaller meals instead of 3 larger meals, and make sure the foods aren't irritating. Because that will help them to get in more calories. They need food high in calories, vitamins A and C, and iron, and generally lower in fat if you can. You're going to educate them on dumping syndrome, especially if they opt to have a gastric resection. And you're going to monitor their weight to make sure they haven't lost too much weight too quickly. Monitor intake and output to make sure that they have good kidney function. Assess for signs and symptoms of dehydration, especially if they don't really want to take anything in. And you can have dietary be consulted as well. Make sure you maintain their pain, provide psychosocial support. If you're there to do something and they want to talk, let them talk. It's about them. It's not about, the tasks that you need to check off. If they do have to have gastric surgery, they can have a resection or total gastrectomy. If they have a total gastrectomy, then the stomach, duodenum, lower portion of the esophagus, the supporting mesentery, and the lymph nodes are all removed. The patient needs to know what's going to happen during the surgery, as well as what's going to happen with recovery, post-op, signs and symptoms, potential complications. They need to know everything. Assess their nutritional status beforehand and talk to them about diet and what to expect afterwards. They can have a hemorrhage, dietary deficiencies, bile reflux, dumping syndrome, and goo. Those are the main complications after surgery. Dumping syndrome can occur after a resection because of removal of the pylorus. Early signs and symptoms occur 10 to 30 minutes after the meal. They include early satiety, abdominal cramping and abdominal pain, nausea, vomiting, and diarrhea. If they have vasomotor symptoms, then they'll also complain of a headache, flushing, feeling warm, diaphoresis, dizziness, palpitations. They may complain of being drowsy or faint, or they might actually faint, have syncope. Early symptoms will generally resolve within the hour, and then they'll have later symptoms of hypoglycemia. This is because their body has this rapid elevation in blood glucose. Body tries to compensate by excreting extra insulin, and then the patient becomes hypoglycemic, generally 2 to 3 hours after eating. As far as interventions, you're going to definitely monitor their pain, make sure that they're doing leg exercises, they're ambulating so that they don't get any blood clots, make sure that they have their incentive spirometer so they don't get atelectasis or pneumonia, make sure they're doing coughing and deep breathing. They need to be repositioned. You'll put them in a Fowler position. You don't want to put them supine. They might have an NG tube, and so you want to make sure that the NG tube is functioning appropriately. And then they do need nutritional care, and again, you can have dietary or nutrition consult for that. Gastric retention is a potential complication, and so the patient, if they start to eat or start the liquid diet and they're not able to actually digest, they'll be put back on an NG to decompression. Bile reflux, they can have medications for that. And because you have the gastric resection, you might have malabsorption of vitamins and minerals, so they can take medications for that. As far as supplementation, they can also have parenteral administration of B12. They can have it sub-Q. Dumping syndrome, we already talked about. And steatorrhea is fatty stool, so reducing fat intake. And then you can also administer loperamide, and that can help. As far as self-management of diet, it takes a lot of education. If they're prone to spasming, they can take antispasmodics. They need smaller meals. They should have fluid separate from the meals. The meals should have more dry items than liquid items. That can help. Know what the dumping syndrome signs and symptoms are. Lie down after meals, and this will kind of slow down the peristalsis and the symptoms from dumping syndrome. Eat smaller meals more frequently, and then take their supplements. So initially, trying to implement all the interventions can be extremely overwhelming, but because it's best to write everything down and to track when they should eat, when they should drink, when they should take their medications, when they should rest, and they should keep like a little journal